Disorders of sexual development have often been considered as a medical and a social emergency. But what's been often ignored that it is actually an emergency for the doctors who rush towards going to the books to the various things as to how to evaluate an individual with DSD. DSD will focus on the entire aspects of disorder of sexual differentiation, ranging from pathophysiology to classification to evaluation and management to DSD, which is going to focus about disorders of sexual development, which is a very intriguing topic, a very interesting topic, which is often causing a lot of confusion with regards to evaluation and management. Website learning.growsociety.in, from which we are webcasting this event, where we have got multiple options available for learning in the form of our Master Pediatric Endocrine course over 18 months, covering nearly now 100 modules on everything related to pediatric endocrinology. So if you want to learn, you've got each and every aspect which is there, using videos, using text, pre-test, case scenarios, and everything available. We have recently launched a Pediatric Endocrinology for Postgraduate program, which again is covering a number of learning modules specifically for postgraduates for a 3-year period. All of you can have a look at a book which is available, and along with that we have the mobile application basically, which is covering in that perspective the various aspects of management of pediatric endocrine disorders, including the approach pathway, the management pathway, the personalized management care, and there are various ways you can use. It's a very intuitive form in terms of evaluating patients with different disorders of pediatric endocrinology. And these are available on Android and iOS. You just have to look at two things: Mullerian structures and gonads. So if you have got only Mullerian structures, no gonads, it's XX DSD. If you have got gonads with no Mullerian structure, it's XY DSD. If you have got both of them, you're talking about an AMH problem or over testicular DSD. If you have got no testes and no Mullerian structure, it's anorchia or XY DSD. Now, a few tips to remember: when you feel a gonad in a child with atypical genitalia, it usually is testis. Now, testis usually is a round structure. It has got similar consistency. If you find areas which have got different consistencies, it may actually mean that this may be a over testis in that perspective. Similarly, sometimes fallopian tube may actually prolapse, and that may give like a gonadal appearance. So you have to be a bit cautious. For Mullerian structures, you can do three things. You can look at a rectal examination, look at ultrasound, or look at AMH. So if your AMH is undetectable, it basically means that there would be a Mullerian structure which will theoretically be present from there. Now, in that perspective, if we then move forward with regards to the further evaluation, go in terms of the workup now, and we'll talk about the various investigations, when to do, what to do. It becomes very confusing because always, whenever I give a talk on this, there's always a question: what is the best time, which test to do, how to interpret, stimulation, no stimulation. So we've done a very, very systematic and simplified approach out here. So in a way, the workup will include the basic hormone tests, particularly electrolytes and 17-OHP, especially if you have a non-palpable gonad. Non-palpable gonad with atypical genitalia is equal to CAH unless proved otherwise. So this becomes important. If you have got a palpable gonad, then this LH, testo, and AMH become important. So while I'm talking about all these investigations, we need to prioritize in that setting. Similarly, investigations like DHEAS, Androstenidione, DHT, and inhibin A, I would say we should keep at a second line. So we are trying to simplify workup with easily available investigations and not complicated it too much. Imaging has a role, of course. Ultrasound, as I said, will tell you about the Mullerian structure being present or not, and we can look at the karyotype, which will give you the genetic diagnosis. If it's not available, it takes too long a time, you can look at FISH for Y chromosome, or you can also now look at the targeted sequencing or the next generation sequencing in that perspective. Now, the most important investigation in somebody who has got a non-palpable gonad is 17-hydroxyprogesterone, because you want to exclude 21-hydroxylase deficiency right at the onset. The precaution, however, is that do not rush. Crisis because of 21-hydroxylase will not happen before 3 weeks of life. So you wait till around 72 hours. Do an extracted sample, because there are a lot of these metabolites which are circulating in this age group, and interpretation, if the level is really high above 100,
that will suggest the possibility of it being 21 hydroxylase deficiency. 10 to 100, it's 3 beta or 11 hydroxylase, because they can have mild elevations in terms of 17-OHP, and in between you can do a ACTS stimulation test as well. If you talk about the assessment for somebody who has got a palpable gonads, you have to basically look at the various factors. What you need to remember is that testosterone levels may be unreliable beyond the mini puberty. So the best test for the Sertoli cell function is actually AMH. Inhibin B has a role later on. So if somebody comes to you around 9 to 12 years, which is unlikely for DSD, you can do Inhibin B, but otherwise AMH is good enough. If somebody is beyond mini puberty, so pretty much beyond 6 to 12 months of life, you can think of doing a HCG stimulation test, giving HCG and seeing that. So if the inhibin is about 35, post HCG testosterone is more than 200, and AMH is detectable, it means that there is a functional testicular tissue. Now, why would you do a LH? LH is the best marker for somebody who has entered mini puberty or not, and it gives you information about the possibility of overall whether you need to do a HCG test or not. So it provides information about mini puberty and gonadal failure. It should be done after 7 days of life, because there is a fall in LH, immediate surge, and then it should be done after 7 days. The interpretation basically, if the LH is more than 0.7, suggests that somebody has entered mini puberty. If it's very, very high, it may indicate gonadal failure. And of course, if the levels are very, very low, you can do a GnRH test or a HCG test in that regards. Testosterone levels are important mainly to look at the gonadal function and to distinguish between the deficiency versus resistance. They should be done again after 7 days of life using a GCMS. So if you have somebody in the first day, you can do a LH in testosterone, but usually patients will come later. So after that, you should wait for at least 7 days to identify. GCMS is important because again, a lot of these other metabolites which are there. Interpretation, if it's low, it's a steroidogenic defect. If it's high, it's 5-alpha reductase deficiency or AIF in that situation. DHEAS is a marker of adrenal androgen production. I would say it's not very, very important right at the beginning. But if you have somebody who has got gonads which are palpable, testosterone which is low, then you start thinking of DHEAS, because this will tell you which is the site of that particular defect. It should again be done in an extracted sample with GCMS preferably. And if it's low, in somebody who has a XY DSD with a low testosterone. So XY DSD, low testosterone with low DHEAS suggests a very proximal defect, star and side chain cleavage. High, it's 3 beta HSD in that setting. If you move forward from that block, you talked about DHEAS. Now we talk about Androstenidione. The role basically is for 17 beta HSD. It will be very high there. Again, after 7 days, and if it is not, LH is not more than 0.7, do a HCG stimulation. Testosterone to androstenedione ratio, if it's less than 0.8, indicates a 17 beta HSD effect. Dihydrotestosterone, you're moving down that same cycle, which Chetan had discussed a lot. So this is a marker basically for the 5-alpha reductase deficiency. Again, after 7 days, if the testo DHT ratio is more than 10, it means you're dealing with 5-alpha reductase deficiency, while if it's less than 10, it is AIS. However, there are a number of studies which have shown that these are biochemical tests and they may not be foolproof. You may have an overlap. So if there is a real doubt, getting a genetic diagnosis may be more useful in that perspective. AMH is very important. The role again is mainly for Sertoli cell function. If you are not very sure about the Mullen structure, you can look at the AMH level, and this will be helpful. Any time of the day you can do it. It's a peptide hormone, so it is not affected by steroids, no need of extraction. If the levels are more than 30, they go in favor of a functional testicular tissue, while in a XX it's less than 10. So it's a big dichotomy. So it's a good test to really look at whether the Sertoli cells are there and they are functioning or not in that situation. And if you have very high AMH, of course, that's a resistance, very, very rare situation in that setting. Inhibin A, Again, a very rare test. I would not do that very often, but this may be a marker of ovarian function. It will give you, particularly if you have a borderline case like XY, XXY, the question is, do you have a ovarian tissue? We talk about that. If you talk about X0/XY, we always talk about, is there a testicular tissue, and do a HCG test or a AMH? It's the opposite way. So if you have got a male appearance and in that you've got a double X basically, which is there in the form of a mosaicism, the question is whether the ovaries are there or not, because if the ovaries are there, you have to take it out. In that case, you can do a baseline and a HMG stimulated inhibin A, and if inhibin A is detectable, this is ovarian tissue. So these are two distinct situations. You're talking about testicular tissue in an XX individual. Very important because it will cause virilization, and gonadectomy may be required if the situation is like that. And ovarian tissue in a XY individual, because then you have to remove it out. HCG stimulation test is predominantly required if you are not in the mini puberty. So most patients will come around when your LH is more than 0.7. You don't need that. But if the LH is less than 0.7, you can do a HCG stimulation test. Now you do a baseline androstenedione, testosterone, and DHT, give HCG, and then after 72 hours you do the report, and you will get the interpretation based upon that. ACTH stimulation test basically is for borderline 17-OHP, when you are basically in doubt whether you are dealing with a possibility of a different steroidogenic defect. So in that case, you do adrenal function assessment. So you give 17-OHP, pregnenolone, and DHEAS. You give ACTH and see how it increases after 60 minutes. It will give you the which form of steroidogenic defect you're looking at in that situation. Now, if we now go into the specific situation, if you have got a very high DHEAS in the setting of XX DSD, you should start thinking of 3-beta-HSD, and in that setting, the test to do would be 17-hydroxypregnenolone. If you have a XX DSD with salt wasting, you're thinking of mostly 21-hydroxylase, 17-OHP levels more than 100 would be characteristic. If you have salt wasting with mild elevation, think of POR, 3-beta-HSD can also cause a mild elevation. If there is hypertension, hypokalemia, alkalosis, along with XX DSD, you think of 11-hydroxylase and do 11-DOC in that situation. So if you now summarize is that if your 17-OHP is more than 100, don't bother about anything else. This is 21. If your 17-OHP is high, DHEAS is also high and DOC is normal. So we're talking about 10 to 100 nanogram per ml 17-OHP. This is 3-beta-HSD. If you have got 10 to 100 17-OHP, high DHEAS, but very, very high deoxycorticosterone, you're dealing with 11-DOC in that setting. And you can also have a variation of POR, which may happen in that situation. Now, if you go to the other way around, so this was the androgen excess in the setting of XX DSD. If you go on to the XY DSD, where you have a problem of any of this steroidogenic pathway, most important, the first one would be Smith-Lemeli-Optis syndrome, which you will consider with mild salt wasting, mild DSD. Sometimes it may cause reversal, but usually there's mild. Your aldosterone levels will be low and your lipid levels will be very low. If you talk about side chain cleavage of star, all metabolites will be low. For 3-beta-HSD, DHEAS will be high, 17-hydroxypregnenolone will be high. For 17-hydroxylase, you will have hypertension and you will have a high level of 17-DOC. For 17-beta-HSD, you look basically at the DHEAS and androstenedione levels. For 5-alpha reductase, you look at testo to DHT ratio, and then this will also differentiate between 5-alpha from partial AI. So whatever test we're discussing about will really help you classify the different forms of DSD in that perspective. So if you have DHEAS, andro, testo, DHT, you will know the diagnosis. So first case, you've got low DHEAS, low andro, low testo, low DHT. Diagnosis, Pratik? So if all are low, you're talking about a very proximal defect. High DHEAS, all the other low. So that will be a POR 3 beta, or really 17 hydroxylase also will be there. You've got high DHEAS, high androstenedione, low testo. That is 17 beta HSD. You have got high DHEAS, high andro, high testo, low DHT. 5 alpha reductase. All high, 5 androgen insensitivity. So if you just remember these 4 into 5 table, which looks like a bit complicated, but very simple if you think about it from your steroidogenic pathway. If all low, proximal, all high, resistance. If you have a predominant increase in DHEAS, you're dealing with 3 beta. If you have an andro excess, it is 17 beta. Testo excess is 5 alpha. So it's not a very rocket science sort of a thing. It's a very simple thing to understand if you now remember this table. So there are 2-3 slides which are there in this presentation. If you remember, the one was that gonad and how they appear and disappear, tell you about XX, XY DSD. One is this one, and one for XX DSD. You will know exactly where you are heading in terms of evaluation and management. Now, genetic testing is important, very importantly for XX testicular DSD, which is very, very important. If you have got a XX male, so to speak, the first thing you will do is SRY, because 90% of them will have SRY. Then you will do NR5A1. If you have a XY DSD, that's a very complicated situation. Now, I've talked about that table, which looks simple, but often there could be confusion. So in XY DSD, we are now moving from a biochemical diagnosis to a genetic diagnosis. So if you're thinking of a gonadal problem, of course, do a NR5A1. If you're thinking of AIS, do a androgen receptor study, and then WT1 SRY would be important from that perspective. If there is gonadal dysgenesis, you have to think of WT1 very importantly, because that could result in renal failure. NRF51 and SRY will also become important from the clinical perspective. Now there are different panels available, especially with the exome sequencing, which gives you a diagnosis, and that will be important from that perspective. Once you diagnose DSD, also look at associations. So for XY DSD, do an abdominal imaging to look for a renal mass. Look for proteinuria. For XY, think of Turner syndrome association. So this will behave like Turner syndrome. Look at cardiac, hearing, and all the other problems which are there. They also are at increased risk for aortic dissection. So all the criteria for echo and everything are the same, which will happen for Turner syndrome. Y cell line, always think of gonadal malignancy, and that becomes important. So now if we just focus on individual evaluation, if you have atypical genitalia in the form of bilateral cryptorchidism, inguinal gonad, scrotal hypospadias, micropenis and hypospadias, look at the first thing. Are the gonads palpable or not? And are the Mullerian structures there or not? If you have got no palpable gonad with a Mullerian structure, your job is very, very easy. So this is a XX DSD, most likely CH, do a 17 OHP. If it's high, it is 21. If it's normal, do DOC, it will be 11. So this will give you diagnosis. If, however, these levels are normal, ask for maternal virilization, which will give you a clue towards aromatase or POR, and all that is normal, then you think of a gonadal dysgenesis. So this arm is easy. No gonads, Mullerian structure present. Very simple. No MH being formed, and this is a XX DSD. Now, if you have a palpable gonad and you have a Mullerian structure, this is also easy. Basically, what it means is that gonads are there, but they are not working. They are not producing AMH, or the AMH is not working. So you do a AMH. If it's low, it is dysgenesis. If it's high, it is AMH resistance. The confusion becomes important if you have got present or absent gonads and your Mullerian structures are absent. What does it mean? It basically means that there was a time when AMH was produced. Now there is no AMH. So it basically tells you that this is most likely a XY DSD, and the evaluation there will start with androgens. Do a DHT level. So you do a testosterone levels first. If testosterone is high, which means it's not acting, you do a DHT. If it's low, it is 5 alpha. If it's high, it is AIS. So that ratio of testo DHT of more than 10. If testosterone is low, it means there is a steroidogenic defect. This could be a combined with adrenal or a local defect in terms of testis. So you look at salt wasting. If there is salt wasting, all that star, side chain cleavage, POR3 beta will come into the picture. If there is hypertension, it is 17 hydroxylase, and if it is normal, it is LHCG receptor and 17 beta HSD. So this whole flowchart may look a bit complicated, but it's actually very simple. You're talking about a 2x2 table of palpable gonads plus minus, Boolean structures plus minus, and then if it's XY DSD, you have to dig deep about testosterone levels, DHT levels, and salt wasting, give you a diagnosis. If you're talking about XX DSD, you exclude CH, and then aromatase, and this is a rare situation of AMH resistance or dysgenesis, you will find that. To simplify all that, we have put forward in our mobile application, the MedEClasses endocrinology app. You just have to answer questions yes, no, and the same algorithm will work quite effectively to identify the case.